Where is he? Where's Ellie? I cannot see him. Where is he? Oh, you're there. Okay, good. I have the honor of knowing Ellie for 30 years. We are family friends also. And he was the first clinical fellow in our lab at UC San Diego. And later on, he wrote many textbooks on the ovary. He has been chairman of OBGYN of Utah. And he's probably the most successful person from the lab. He became medical school dean of Brown University. And he has been really not only working on science and clinical aspect, but recently he go into public policy. You can see a lot of articles he writes in terms of health issues. So a lot of you probably don't know he's actually an accomplished pianist. So you will hear his talk. Everything is very well rehearsed. Every sentence cannot be changed because it's really written in his mind like he's playing recital. Okay. And today he will give a very interesting perspective about the history of the PCO research. Ellie? Thank you.
Okay, technical challenges. Thank you, Aaron. Thank you, everybody, for being here this afternoon. It is my distinct pleasure to take a stab at the history of the polycystic ovary syndrome. By necessity, a personalized effort. Not everybody will be mentioned, and I apologize in advance. It seems plausible to at least assume that PCOS is a disease as old as humanity. And it probably is reasonably plausible, with not too much evidence to back it up, that the oligogenic trait that we all presume undergirds PCOS likely resided in our Homo sapiens ancestors probably before they migrated out of Africa into Europe and Asia, respectively. But today, of course, we will, by necessity, partly time, partly other reasons, limit ourselves to what I refer to here as the modern history of PCOS, essentially 150 years of progress, powered at least in the last 50 years by a substantial growth in the interest in this entity, as assessed by the number of annual PubMed citations, the title of which contained the term polycystic ovary syndrome, or PCOS. But things were not always as upbeat. If we go back 100 years, almost to the day, Albert Goldspawn, a Chicago-based gynecologist, addressing the American Association of Obstetricians and Gynecologists, lamented, "There is still too much difference of opinion in our ranks about follicular degeneration of the ovaries and about its pathological status." He must have been referring to the fact that there are a multiplicity of synonyms and acronyms that we are applying to this condition, making it relatively difficult to define. And quite frankly, some of those issues of definition and of diagnostic criteria continue to some degree to plague us today while we are trying to refine them to a better state. But progress has been made in the last 150 years. We may not quite have arrived at the promised land, but I would like to think that perhaps we are standing on the mountaintop looking in. And so before too long, hopefully, we will resolve this conundrum which has plagued us for so long. With your permission, I divided this part of our history into 4 segments: the descriptive era, the endocrine era, the metabolic era, and finally the genetic or genomic era. By most account, the proximate bookend of the descriptive era is the year 1844, at which point the French physician and historian Achille Shueh provided us with the first published account of PCOS upon the publication of his treatise translated Diseases of the Ovary. In it, Professor Shueh, who was of the opinion that PCOS represented a case of acute ovariitis of the first degree, represented ovaries that are enlarged in volume, with smooth and shiny surface, containing many small cysts located on the periphery of the organ. Professor Shueh's contemporaries, some of them very well known, such as Rokitansky, Virchow, Pfannenstiel, and others, have also subscribed to the so-called ovarian inflammation hypothesis, and indeed for a long time that was the prevailing notion. By the by, as information was being added and as papers were being written, we have nevertheless learned across the way that one of the issues in the context of PCOS is an expanded stromal compartment, and even that amenorrhea and infertility are in fact corollaries of the same, long before Stein and Leventhal made it to the scene. Others, such as Albert Goldspon, who we have already met, subscribe to the view that PCOS was entirely attributable to essentially uterine retroversion and the vascular and congestive consequences thereof. This was a competing mechanical hypothesis to which we later added the views of Clarence Hyde and others who suggested that the primary culprit was really obstructed ovulation. That is to say, the inability of the leading pre-ovulatory follicle to negotiate the thickened tunica albuginea. As we've heard today from Dr. Hsueh and others, when we take this view in retrospect, Clarence Hyde may not have been all that far from the truth after all. So as we review the state of PCOS in 1900, around the turn of that century, I think we can say with some confidence that the histopathology was known, that the clinical presentation was partially known, perhaps with the exception of hyperinsulinemic hyperandrogenism, and that the therapy was essentially ovarian red resection, which now, as you have heard earlier today, we finally have an intellectual framework or an intelligent framework to work around to potentially explain the heretofore inexplicable salutary consequences of wedge resection, such as the resumption of ovulation and ultimately the potential conception. I will say one more thing about this, and that is that the wedge resection was likely practiced well before the turn of the century, and certainly long before Stein and Leventhal made it a household word, as documented by Palmer Findley as early as 1904. And I'm taking the liberty of digressing a bit because we are in the descriptive era, and it is important to recall that much of the progress in this area was always contingent on the development of competent sonographic ways of monitoring the ovarian pathology. That distinction, turns out, belongs to Mark Swanson, a Vancouver-based radiologist, who in 1981, on the pages of Clinical Ultrasound, provided us with the first images of the human PCO ovary. The photograph you're looking at, you will note, has been obtained with an abdominal sector scanner, the likes of which you will be hard-pressed to find in your institutions today. Which brings us to the endocrine era, which improbably, and I would say almost counterintuitively, was ushered in by the so-called Stein-Leventhal report, which was published in 1935 in the American Journal of Obstetrics and Gynecology. The two protagonists, Irving Freiler Stein Sr. and Michael Leo Leventhal, practicing Chicago-based gynecologists, joined in practice, were in effect very involved in the care of such patients, and at the time were associated with the now extinct Michael Reese Hospital, which was affiliated with Northwestern University Medical School. These two gentlemen, who clearly attained eponymic immortality consequent to this report, shared with us the history of 7 women suffering from amenorrhea, hirsutism, and infertility, whose ovaries were 2 to 4 times the normal size, and in whom the ovarian cortex was hypertrophied with a thickened tunica. In addition to enlightening us about the occurrence of hirsutism in such patients, Stein and Leventhal went on to say that bilateral polycystic ovaries are probably the result of hormonal influences related to the anterior lobe of the pituitary gland. 3 words uttered back in 1935, which, to the account of many, have essentially ushered in the endocrine era. Approximately 25 years have elapsed before anything new really happened. And when you think about it, we had the Second World War, and in the wake thereof, approximately a quarter of a century during which no consequential developments are actually worthy of note. But we picked up the pace again in 1957 with a somewhat improbable contribution, largely unknown, largely underappreciated, by Dr. Keitel from the University of Iowa, who reported on 13 women afflicted with what he termed wedge-resistant PCOS. This heroic study that could not, should not, would not have been carried out today, nevertheless treated us to the very first description of ovarian hypersensitivity to gonadotropin treatment. And when I say gonadotropins, I mean ovine and porcine gonadotropins, because we are still 13 years away from FDA approval of human menopausal gonadotropins. This paper also treated us to the first description of the ovarian hyperstimulation syndrome, not a well-known fact. And lastly, this paper treated us to the first documentation of elevated urinary bioassayable LH, a finding that was confirmed a year later by Dr. Janet Ward MacArthur from the Mass General using a slightly different bioassay. That same year, Karl Gemzell from the Karolinska Institute reported on a single case of successful induction of ovulation in a patient with PCO using human pituitary FSH, which of course in those days had to be extracted from cadaveric material. Only 3 short years thereafter, Robert Greenblatt, then at the Medical College of Georgia, reported on the pages of JAMA on the successful induction of ovulation in 8 out of 9 women afflicted with PCOS. Note that we are 6 years ahead of the FDA approval of clomiphene citrate for widespread use, which explains why in this paper, clomiphene is still referred to by its code name, MRL/41. Clomiphene, as we know, served us very well for about 50, if not 60 years. As you know, however, this very year, clomiphene was dethroned in the context of PCOS by letrozole. And as we speak today, in all likelihood, going forward, letrozole rather than clomiphene is king. It took a few more years, specifically 1964, when we finally obtained biochemical affirmation of the otherwise clinical hyperandrogenic state, courtesy of the work of Bill Dignam from UCLA. Only a year later, a power team from the NIH actually reported increased testosterone production rates in PCOS over the pages of JCEM. Lastly, we would be remiss if we didn't mention the seminal contribution of Samuel Yen in 1970, wherein he clearly documented for the first time the so-called inappropriate pattern of gonadotropin release, high LH, normal FSH, both documented with recently available new radioimmunoassays for human LH and FSH. Dr. Yen and others who followed, for a while there, precipitated a body of work, the basic premise of which was the possibility that PCOS just might constitute a primary hypothalamic pituitary disorder. We'll come back to that point a little bit later. Which brings us to the metabolic era, which traditionally is usually bookended in 1921 when Achard and Thiers described the so-called bearded diabetic woman syndrome. And while this was clearly a seminal paper, it did not specifically address the issues of PCOS. And so, in a form of revisionist history here, I'm suggesting we start counting in 1980, at which point a seminal contribution appeared that probably for the first time correlated hyperandrogenism with hyperinsulinism in the context of PCOS, the leading protagonist here being undoubtedly the late Jim Givens. This important breakthrough likewise spurred a large body of studies that attempted to address a whole host of issues, perhaps most significantly the etiologic cause and effect relationship between insulin resistance, compensatory hyperinsulinemia on the one hand, and ovarian hyperandrogenism on the other. Stated differently, the questions that were formulated were, does insulin promote ovarian androgen biosynthesis, or do androgens promote an insulin-resistant state? Two of the same coins. I would argue that the first question, does insulin promote ovarian androgen biosynthesis, to some degree has been resolved by a body of work reported by Ron Kahn, Simeon Taylor, and others from Jesse Roth Group in the late 70s and early 80s, in which the common denominator was a compromised insulin receptor, be it by mutation, be it by immunoneutralization, associated almost in most cases with hyperandrogenism, at least in premenopausal subjects. Consequently, it seems plausible to suggest that the cause and effect relationship between the actors here is such that the primary culprit is probably the insulin resistance and the compensatory hyperinsulinemia, and that the consequence is ovarian hyperandrogenism, with LH likely acting as, with insulin likely acting as a co-gonadotropin. If there's any doubt remaining on this question, there is a large body of information wherein insulin economy was perturbed up and down, and the appropriate consequences in ovarian biosynthesis were observed, be it in vitro or in vivo. Interestingly, The reverse situation, namely do androgens promote an insulin-resistant state, is a little more difficult to resolve in that we have a group of studies that have perturbed androgen economy in a variety of ways and have not observed a change in insulin resistance, while others did. And so the data are somewhat conflicted on this question at this time. Which brings us to the genetic or genomic era, which very inconspicuously started in 1968 with a paper by Cooper and Associates published in the American Journal of Obstetrics and Gynecology. These individuals, all members of the Department of Obstetrics and Gynecology at the University of Minnesota, developed a critical case for the possibility that PCOS was in fact a heritable disorder. Their presumption was that the mode of inheritance was consonant with an autosomal dominant trait. This seemingly improbable paper, again, spurred a significant body of work which brought us all the way to this day, of course, with genome-wide association studies. But the beginning was more modest in that what this spurred was a large effort to carry out familial clustering studies, which essentially reaffirmed the notion that PCOS was a heritable condition, but modified perhaps the genetics, realizing that heritability here was not as simple as originally perceived, and that perhaps we are dealing with an oligogenic trait rather than a more simple variety. This in turn was followed by a large body, at least 70 studies, that carried out candidate gene association studies, many of which were quite enlightening, but at the same time were somewhat compromised by small sample size, by the a priori presumptions that had to be made, and by a variety of other relative shortcomings. Which led us, as technology progressed, of course, to genome-wide association studies, about which you'll be hearing very shortly from Professor Chen, whose thunder I do not wish to steal, and therefore will limit my comments to saying that of the 3 GWAS that were published to date, we are now collectively looking at a total of 12 susceptibility loci. And if I can add anything to this conversation, I would say that perhaps we should take a brief look at one study which, to my mind, represents the shape of things to come. That is to say, follow-up studies to the 12 and eventually perhaps more susceptibility loci that have been uncovered. And the example I chose was a paper first authored by Jan McAllister, senior authored by Jerry Strauss, published in PNAS earlier this year, wherein the overriding conclusion was that DEND1A, one of the susceptibility loci uncovered, that expression correlates with the thecal PCOS phenotype. A conclusion that was arrived at through 3 distinct lines of evidence. First, when these investigators probed normal and PCOS theca cells for the presence of the messenger RNA or the protein for DEND1A, they were able to demonstrate higher expression in PCOS versus normal theca. In addition, when overexpressing DEN1A in normal theca cells, the investigators were able to convert that theca cell into a PCOS-like phenotype that is hyperandrogenic and actively engaged in androgen biosynthesis. Lastly, these investigators have done the reverse. That is to say, they knocked down the DEND1A in a PCOS theca cell, and in so doing, reverted it, if you will, to the normal state. Well, with that all behind us, I'd like now to close with a brief discussion of the difficult cause and effect relationship between the hypothalamus and the ovary. The premise of the conversation from the very outset and for that matter, the subject matter of the title. Perhaps we should begin by exploring the possibility or re-exploring the possibility that PCOS may in fact be a primary hypothalamic disorder, a notion driven by and to some degree spurred by the late Sam Yen. The idea here, of course, would be that the main action would be in the hypothalamus and that the ovary would be an innocent bystander. I would argue that that's, in retrospect, while appealing, probably not a very likely scenario. And I say so because it is very difficult to rule out all the secondary inputs that impinge on the hypothalamic pituitary unit, be it steroidal actors, be it insulin, be it neurotransmitters, or be it cytokines of whatever kind. However, if we were to reframe the question and ask, is it possible or is it true that PCOS comprises an important hypothalamic pituitary component, then I would say the answer is clearly affirmative. And there are many pieces of evidence that would support that contention. For example, there is evidence for decreased central arcuate dopaminergic tone, as reported by Quigley and Associates back in 1981. There is evidence of disordered chronobiology of GnRH release, as reported by Zumov in adolescent PCOS subjects. There is evidence for disordered frequency of pulsatile GnRH release, reported by multiple endocrine authorities, neuroendocrine authorities, of which only a few are shown here. There is evidence for disordered amplitude of pulsatile GnRH release by several neuroendocrine authorities, again, only a sampling of which is shown here. And we have known since 1976 about the increased pituitary sensitivity to GnRH, as reported by Rebar in the Journal of Clinical Investigation at that time. Which brings us to the other possibility, namely that PCOS perhaps is a primary ovarian disorder. And this might be the appropriate time to say that nothing that I say today, of course, can be viewed as either waterproof, ironclad, or in some way definitive, because we are still working on the genetics here, and that's what ultimately will probably carry the day. But subject to current information, the notion that the ovary is in fact the culprit and the hypothalamic pituitary unit is more of a passive bystander, I think has appeal, and in all likelihood may well turn out to be true, although only time will tell. There is a body of information that would support this contention. I will list just a few. One I like in particular is the fact that ovarian PCOS sonotype can be frequently found in so-called normal women. By that I mean normally cycling women, who, by the by, are hypersensitive to exogenous gonadotropin therapy. I would also mention the observation that the ovarian hypersensitivity to exogenous gonadotropin is often maintained in a gonadotropin-deprived state, such as pretreatment with a GnRH agonist or exposure to long-standing chronic hypogonadotropic hypogonadism. In both cases, the innate hypersensitivity, if you will, sensitivity to gonadotropin seems to be in place. And let us not forget that some of the GWAS susceptibility loci are in fact ovary-specific or related. Ovary-specific, of course, would include the LH-HCG receptor and the FSH receptor. Ovary-related would be YAP, insulin receptor, DEN1A, and perhaps others. In many ways, the situation we find ourselves in today is reminiscent of the so-called going around the squirrel conundrum, written by and about William James, the famous American philosopher and psychologist. Seems James heard a squirrel scratching on the unseen side of a tree. James circled to his right, and the squirrel did as well. No matter how quickly James moved, the squirrel moved just as quickly and thus remained unseen. It would seem that we, the collective discipline, are a tad like James, and that the squirrel, at least for the time being, remains unseen. Thank you very much.
Any question? This is so much authority. That's why he always writes textbook. And there's one question. Good.
I have to add a comment. I sent Ellie. These are both my teachers. I had the privilege of being taught by both of them. I sent Ellie a publication I happened to publish about the first, what I believe is the first description of the polycystic ovary. It's an old, 700 years old commentary on the Bible, which tried to explain why the mothers gave the permission to their husbands to have a second wife. And the guy goes to explain, he says it is well known that overweight diminishes the fertility of a woman. And these women planned to become depressed by the fact that their competitive, the other wife, will have a child. By this way, they will lose weight and conceive. So I don't know if the hypothesis stands for the mothers, Abraham's wife and Jacob's wife. But I know that this guy understood the mechanism of polycystic ovary. So, but Eli, even though he can read Hebrew, did not accept it. So I wanted to say that for me, that was the first description.
What I did is, when I got this email, is I claimed secularity. We've got enough of this stuff in this country and elsewhere, and so I stayed away from it. Thank you.
Thank you, Eli.
My pleasure.
Well, so Eli really set up the session on PCO, and we're going to continue with some of the recent